Good afternoon to you all. It is our pleasure to welcome you to this first ITM alumni webinar, which will be focusing on how Uganda fights the COVID-19 pandemic, drawing on their experience from earlier disease outbreaks. In the ITM alumni webinars on COVID-19, ITM alumni present their impressions on the current situation of the outbreak in their country and highlight how they are engaged in this global fight against the pandemic. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and wider global health community. I will just explain a couple of practicalities for this webinar. If you would like to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. Questions will be moderated and only a select number of questions can be discussed given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. You can, however, use the forum function in the online alumni platform to start a discussion on your questions left after this webinar, and also, of course, follow the next ITM alumni webinar. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on YouTube. You will get a link through email, together with also the announcement of the next upcoming ITM alumni webinar. I will now introduce you to our moderator, Professor Dr. Marianne van der Zande. Marianne van der Zande is head of the Department of Public Health of ITM since July 2017. She's Professor of Public Health Epidemiology. Before joining ITM, she was for 10 years state epidemiologist of the Netherlands, heading the Center of Epidemiology and Surveillance of Infectious Diseases at the Dutch National Institute for Public Health and the Environment. She has been working in Darfur, Sudan, Soroti, Uganda, in Zambia, and in the Gambia. As a professor of public health epidemiology, she was also Salome Okwaris, one of the speakers' thesis promoter, which was also on the topic of emergency preparedness. And Marianne van der Zande is as well the course director of our new short course entitled Outbreak Investigations and Research, which will be kicking off 20th of April of this year. Okay, Marianne, please.
Yes, thank you very much. So I'm very happy that I have been asked to moderate this first session. I think we have excellent speakers. I think Uganda is really has a lot of experience, and I worked with Salome closely when she wrote her thesis on preparing for the preparedness on health security threats, comparing what was advised and how it worked in practice. And she's currently heavily involved in Uganda in the preparedness for COVID. I have great interest in the experience we're going to learn from Uganda, and maybe Uganda will also be able to benefit from all the experience of all the other alumni present from all over the world.
All right. Good afternoon, everyone. I'm Salome Okwari, working with the Ministry of Health in Uganda, and I'll be the first speaker. I can just share my... Okay, if you can all see that. We're going to be discussing, as was mentioned already, Corona in Uganda, and I'll take you through the preparedness phase and then part of the response, and then the later part will be done by Henry Chobe, who is a little delayed, but he will join us. So this is a general outline of how the presentation will go. We will go through preparedness in Uganda, response to COVID, what we gained from the past, challenges and then changes to the surveillance strategy that we are using in Uganda. As I start the presentation, maybe I can explain where I'm placed in all this. I'm part of the team that is the incident management team that supports the coordination of all the other activities that are run during the preparedness and the response. So it's from that lens that this presentation is made. So you'll see a lot of overview, and I hope that I'll give enough detail. So I think we're all aware that in January, China declared that they had discovered a new virus. It was named COVID. It was named SARS-CoV-2. And by the end of that month, we had spread to nearly the entire world. And by the end of January, WHO declared that it was a public health emergency of international concern. I think I'm sure that everyone, even those who didn't know anything about a public health emergency of international concern, at least now are familiar with the term. What it means is simply that everyone in the world needs to get prepared because you're about to be importing cases or you're about to be hit with the same outbreak that's in another country. The only problem with that plan was that in January, there was a lot going on in Uganda. Now, Uganda is a country of about 42 million people. Our total expenditure on health as a percentage is 7.2. So you can already see that there's a little bit of underinvestment. It's landlocked. So we are totally surrounded by Kenya, the Democratic Republic of Congo, South Sudan, Rwanda, Tanzania. We lie close to the Congo Basin, the Meningococcal Belt, and the filovirus triangle. Those are all very important in understanding what exactly happens in Uganda. Now, in January, when we reported on the 1st of January to work, this is exactly how we were. There was a resurgence of the measles outbreak that had been stopped the year before in September. We had a yellow fever outbreak in at least 5 districts in different parts of the country. There was a Crimean Congo hemorrhagic fever outbreak that was building on from where Rift Valley fever outbreak had just stopped. There was threat from Congo because they were still registering EVD cases. Then in the middle of that, there was a malaria upsurge. So we also had an outbreak of malaria. Then while we were still dealing with that, there were locusts on the way from Somalia, channeling down through Kenya, through Turkana, to a part of Uganda that's semi-arid, and therefore food security is not the best. Then on the bulk of all this, then we got COVID. So this is just to give you a general picture of what our January was like. I'll go over the preparedness activities. We conducted a preparedness assessment using the WHO country assessment tool, a very simple tool that looks at presence and absence of certain requirements that you need in order to respond to a respiratory pathogen. It gives you an overview of what you have in place and what you do not, but does not go into great detail as to what you need for those specific things. So that was number one. And in order to supplement that preparedness assessment, we conducted a risk assessment, just trying to see how exactly were we more likely to get COVID cases in Uganda, which areas in the country would be most at risk, and what should we do to prepare them. The first thing we identified was the high risk for points of entry, identifying mainly the airport, and then the border crossings that bordered countries where there was a lot of traffic. So along the Kenya border, that's Malaba and Busia ground crossings, and near Rwanda, that is Chanika and Mirama Hills. The second area identified as high risk were points of high congregation. So the cities where we have a lot of incoming traffic, where someone who is able to travel abroad will more likely live. So those are the bigger ones. Then the second important area were places where we had a lot of construction being conducted by individuals that were more likely to have come from outside of the country. We built on our pandemic influenza plan, which was still in draft form, but had identified very quickly the need to move from a situation of no cases to very many. We applied our national disaster preparedness policy, which gives a clear guidance as to when you should escalate response activities to a higher level and when you should maintain it within the Ministry of Health. And we also developed a scenario-based preparedness and response plan. The scenarios covered three things. 1, no case in Uganda. Scenario 2, a single case or cases in a single location. And 3, multiple cases in multiple locations, which we soon realized we moved through very, very fast. This slide simply highlights the blocks of Uganda's response. There are 5 main pillars that are guided with others. There is case management, safe and dignified burial, which covers the clinical care, clinical trials, water and sanitation, infection prevention and control, and screening. Then there is surveillance, epidemiology, laboratory, which covers mainly medical surveillance and laboratory-based surveillance. So it will cover contact tracing, case finding, sample collection, reporting of results, data management, and reporting. Then there's logistics and security, which will support like the salaries, the fleet, and the different clinical needs that you might have. We also have social mobilization and health education, which covers the medical anthropologies, the communication to the public, and then communication with key figures within the society that can inform decision making. All these are also supported by different smaller pillars, but held in the middle by coordination. Now, coordination also links to media. It's very important to have the media linked to coordination, because when you have it linked to different pillars, then what you have is inconcise communication, conflicting often and not succinct with what the problems are. You also have psychosocial support that bridges between social mobilization and case management and provides a psychosocial base for those responding and those who are affected by the outbreak. Our management strategy was very, very simple: control at source. There was no other option. We weighed all options and realized that if we did not want the outbreak to overrun the health system and set us back with several gains, then what we needed to do was ensure that control the outbreak early on and right from the source. So it focused on detect, prevent, respond, and backed up by infection prevention and control, both at health facility level and also in the community. Under detect, we looked at early detection. So that is very quick screening, very good triage, so that cases are identified at the earliest opportunity and dealt with. This was very, very good, including airport screening and screening at health facilities. And that's how actually we were able to detect our first cases. Then under prevent, we looked at interrupting transmission. So where we have cases already identified, how do we stop the community transmission so that we don't get an outbreak that is out of hand? And respond involved aggressive supportive care. So in the hospitals, how do you give the support that one needs, clinical support, psychosocial support, but at the same time, how do you respond within the community in such a way that you don't give the outbreak an opportunity to expand? The principles guiding the development of the plan were 5. 1, it needed to be multidisciplinary. 2, multisectoral, simply because of the massive involvement that would be required in order to respond. 3, a whole of society approach, recognizing that even the individuals within the society, within the community, were responsible for their health in this case, provision of care to the infected, and continuity of service delivery despite what was going on. The measures instituted were the following. 1, travel advisory with travel restriction was disseminated, highlighting Category 1, Category 2, and Category 3 countries. Category 1 countries were those identified with either massive number of cases, an exponential increase in cases over the last few days, or countries that had reported continuous high incidence of cases. So just increasing the chances of someone being infected, therefore bringing the infection back into Uganda. Established capacity for case management. So the first thing we did was designate isolation facilities so that you have clear understanding between facilities that are required to care for COVID and those that are going to continue provision of routine healthcare services. Then we trained healthcare workers in these facilities to care for and identify the COVID cases, and then trained the armed forces, because the armed forces are ready at a moment's notice and therefore would not be complicated to deploy at short notice. We also instituted enhanced surveillance activities, including active case search, risk communication and community engagement activities, and quarantine, initially providing self-quarantine, but eventually this became institutional quarantine. During the response phase, we identified our first case on the 21st of March 2020. The case was identified through airport screening, which was very interesting at the time because several countries had highlighted the uselessness of airport screening. He was a 36-year-old male returning from Dubai in the United Arab Emirates. He was identified with an elevated temperature and was quickly rushed to the isolation facility where a sample was taken off and it was found to be positive. So these are the measures that we put in place after finding that first case. As I mentioned, I don't know if you got it, I mentioned it was a 36-year-old male identified through airport screening. The measures instituted were: 1, we isolated the case at Entebbe Hospital. It was an isolation facility we had placed close to the airport so that the individuals that are identified through airport screening would not reach the general population. The second thing that happened is United Arab Emirates was added to Category 1, which it had not been before. Then institutional quarantine became mandatory and there was no more self-quarantine. And then we enhanced surveillance even further and started inviting people who had traveled to any of these countries that were in Category 1 to come in freely for screening. And on day 1, the number of individuals that showed up at the screening point was close to 200. So there was a lot of buy-in already from the population. This is an epi curve of the 52 confirmed cases that we have in Uganda right now. If you look, it's a little up and down, but never going above 10 cases over the entire period. This is the first case we identified at the airport. These were identified through airport screening the next day, and this in the middle is the part that was identified through the callback and quarantine screening. This just shows you the measures that had been put in place at the time when the cases were identified. These peaks apply to travelers from Dubai, and then this is a peak from a team that came in from the UK. If you look at this map, this is a geographical distribution of cases and contacts. Red is the cases and orange is the contacts. You can see that there is some clustering within this area. So that's Entebbe, and that is Kampala. And that is where most of the contacts are. The same thing on the left, this is Hoima, and this is where most of the contacts are. There's also a case in Adjumani, which is in the north. This is some general data on the first cases that were seen. We set up 29 quarantine sites with a total of 1,197 that were under quarantine. And out of that, we identified a total of 24 cases through the quarantine. Yes, and about 12 cases were identified outside of the quarantine. And these are the measures that continue to be in place. One, we quarantined everyone that came from United Arab Emirates. So set up a huge operation of moving these people into quarantine sites and maintaining them there for the entire time. We also heightened risk communication. Again, as I mentioned, it's the kind of disease where you really need the population buy-in. Otherwise, you're not going to have any impact in many of the interventions you set up. The public transport was stopped, which resulted in disturbances in provision of routine healthcare services. But I think this is slowly being settled down. Then mass gatherings were stopped. Everything that included large meetings, so all international conferences were cancelled. Churches and mosques, that kind of religious gathering was also stopped. Then mass weddings, or in the words of our president, he said Ugandan style weddings, where you have close to 1,000 guests attending one wedding, or funerals where you have close to 500, 1,000 guests, 1,000 mourners gathering. What he instituted was something that is called a scientific wedding, where you couldn't have more than 10 people at a wedding. It might seem normal to some, but for the Ugandan, it's a really huge sacrifice for someone to have just 10 people. What it also meant was that there was going to be some economic impact for people who deal particularly in the service industry. So for people who do catering or events and things like that, it really had a negative effect on their businesses. Then emphasis on social distancing and hygiene was promoted. These are the challenges. I think this is my last slide. These are basically the challenges that we've faced in this time. Number one, coordination. This is the kind of response where it's not just Ministry of Health involved. There's so many different actors that need to come in to take part in order for you to have a sensible response. Secondly, a rapidly evolving situation. I mentioned that we had planned for 3 scenarios, and in planning, you always think that you're going to jump from scenario 1 to scenario 2, scenario 3. We went, I think, from 1 to 3 in a matter of 48 hours. So the way that we approached the response almost needed to be in a moment-by-moment manner. Then running of routine services was a bit of a challenge initially, particularly with stopping of public transport and getting health workers to their places of work. Then the infodemic, which I think everyone is suffering with, too much information, too little verified. And then the cost of running quarantine is astronomical. So for many countries, they wouldn't even consider doing it as institutional quarantine, and the government is paying for it. But what it has resulted in is identification of cases early before they can have a chance to transmit within the community. Thank you.
Thank you, Salome. I think this was much appreciated. There's several questions already on the on the Q&A, so clearly you can add them, and I'll try to post some of them to Salome, and we may still have some input from Henry, but I understood he's very busy at the ministry. One of the questions is about what people call collateral damage, that how can you ensure that, like, for example, the TB reference laboratories can still continue to work, that it's not that while fighting COVID, that the major problem with TB is not suffering. I understood that the reference laboratories are trying to coordinate resources, but how did you deal with this in Uganda?
Here, the TB reference lab. So the way that samples move in Uganda is through a hub network. So someone collects a sample from one place, and then the samples are transported. Now, the lab that is doing the TB testing is completely different from the lab that is doing the COVID testing. So those are two completely different systems. So one is mainly a virology lab, and the other one is specific for TB. So because the systems are different, they've not necessarily suffered. What may suffer is the fact that maybe the number of health workers that are attending to these TB patients is a bit of an issue, or the TB patients themselves failing to get to the health facilities because of restrictions of movement. But the way that Uganda is structured is that these services can continue to function simply because they're two completely different services.
Okay, so the supervision can still continue also?
Yes, yes, it can.
Okay, I think that's great. I think the people who are more interested in that, they can contact you to have more details, because I see there's many questions at the moment. Are you preparing for a scenario where transmission is no longer linked to incoming travelers?
Yes, that's what we are in the process of planning right now. We have already had a definite 5 cases who contracted the illness from within Uganda, so contacts, but these have been like first-degree contacts of the cases. So spouses, children, those are the kind of people that are contracting right now. But as we continue to think about the fact that many people must have gotten into the country, must have passed through airport screening, we are also changing the way that we are thinking to focus more on surveillance at the district level. Another activity that we're doing is shifting from this medical surveillance that relies heavily on a certain set of symptoms that fit a case definition to more of a lab-based surveillance. So everyone who has traveled out of the country to be contacted, and then to see if they may have had an illness in the last 6 weeks, and then start contact tracing, or at least building a map of where those cases might have infected.
Okay, and at the moment, is there a recommendation for the population to stay at home, or is it compulsory, or there was some confusion on that?
Right now, there's a recommendation for us to stay home. We seem to think that it was a lockdown, but quite a number of people are out and about. The recommendation right now is to stay home. There's a strict movement restriction on private vehicles. So mainly it's government vehicles that are allowed on the streets, essential services from other government departments, and the healthcare workers. So those are basically all the private cars that are allowed outside. But movement between districts, between towns, between cities, that is under complete restriction. So in order for you to move from one part of the country to another, you'd need to get a pass for a certain amount of time. Yes, and that's part of the measures that are being put right now.
Okay, so because the contacts seem to be gone all over the country, how is that possible if there is a quarantine for travelers?
Okay, the cases that were identified in Hoima, that was the case that went through the airport screening with no symptoms, and then went home. Then presented at a screening point because we put out on mass communication and social media. Everyone who's traveled to Dubai or these countries within this time period should present to a health facility for testing. So tons of samples were sent in. Nearly 1,000 samples were sent in from around the country. And the individual from Hoima, that's in the western part of the country, that's how he was identified through that screening. The individual from the northern part of the country has actually, his only interaction with movement outside the country was a visit to South Sudan. But at the time, South Sudan had not declared any cases. But I think it's been 10 days since we identified that individual, then South Sudan declared that they do indeed have cases. They've identified 2. And I'm sure moving forward, they might identify more.
Okay. There's several questions on, is there any recommendation on face masks?
That's a very contentious issue. Right now, the recommendation from WHO and from the Ministry of Health is to focus the use of face masks on the healthcare workers. There isn't any, we don't yet have clear guidance on the use of face masks for the general public, but because of the limited stock, the global shortages, and just the number of cases that we have right now, the prioritization for face masks is for the healthcare workers mainly.
Okay. Yeah, I think that's clear, in line with WHO. Another question is about, did Uganda apply the GE as part of the global health security agenda, and was this useful? I think this is also something you studied for your MPH. So,
yes, we did. We conducted a JEE in 2017, and it was very useful at the time. We used it to assess for different gaps in our system, identified areas that needed improvement, set those into our National Action Plan for Health Security, which we launched last year in August. And we're in year 1 of implementation. And on the global health security agenda, Uganda was actually one of the pilot countries for the global health security agenda in 2013 and 2014.
Okay.
Yes, it's actually a very useful tool.
Okay, because that was the question. What, you used it and you found it useful. So I think that's good for other people to realize. I'm moving a bit quickly because there's so many questions. They only continue because people are really impressed. So there's several questions on testing. What is the testing policy? How many do we have available? The lab capacity.
Okay, testing.
Mm-hmm.
Currently, we have one lab that is testing, the Uganda Virus Research Institute. So I already spoke about the hub system. So all samples get shipped from across the country. Samples should be there in at least 12 to 24 hours, and then they're tested. So everyone receives results within 48 hours of taking off a sample. We are trying to expand that testing capacity as new tests come in. Right now, all that we have is the PCR testing. So that's why it's limited also within that one testing site. But as new modalities become accessible, that testing capacity will expand. For example, we recently received kits that do an antigen testing, quite similar to what is seen in GeneXpert. So as that becomes more available, as those are validated, those will be expanded to different parts of the country to shorten that time period. Also in anticipation of what happens if we have massive community transmission. Yes.
Okay. So
I forgot to mention the private, sorry, I had to mention this, that private sector is also being looked at as another avenue for expanding this testing capacity, just so we have as much as possible, and we are employing that whole of society approach.
Okay. And you have sufficient tests at the moment?
Yes, I can say we have sufficient tests at the moment. But okay, if we say that we were going to test all the 42 million Ugandans, then no, the answer is definitely not.
Yeah, and how often do you test? Okay, then there's some questions about vulnerable populations, both people who become, people not having secure jobs, but also people in camps or other populations, how to protect them, how to, what strategy is there?
Multi-sectoral approach camps. Uganda has the highest number of refugees, over 1 million refugees, and more keep coming in from South Sudan, from Congo, from around the region. And a lot of the operations in the camps is run out of the office of the Prime Minister that oversees and works closely with the UNHCR. So as part of our training modality, in order to quickly recognize, to do their preparedness plans for those small congregation points. The refugee points, similar to prisons, to military camps, can't be decongested. It's where they are, and it's where they are. So very many measures have been put in place, mainly for screening and setting up treatment units within those. For the vulnerable populations, there is a move from the Office of the Prime, this is coordinated through the Office of the Prime Minister and Ministry of Gender, Labour and Social Development to ensure that at least meals are provided for the vulnerable poor. Whether that is sufficient and whether it covers all the bases, we will see as we evaluate, but for now, that is how we are caring for them.
Okay, there's questions like this quarantining and this lockdown. Do you have evidence that it's really working? And for example, and there's also a related question, like you put people from certain countries. Which travelers are put into quarantine, and all travelers, or also people only from specific countries?
So the quarantine was instituted for travelers from category 1 countries. I can share a list. So basically any country that you can think of that had high transmission. Right now I should have mentioned this. Right now our borders are closed to all travelers apart from cargo. Yes, so it was one of the measures. Yes, it was one of the measures.
Most countries are category 1 countries by now, it seems. So
yes, so everyone is a category 1. So it was basically countries that had high transmission; those were put into quarantine.
Okay. There's still some more questions related to other health services, like how do you prepare for malaria outbreaks, vaccination programs? How do you protect them? Can you say something about that?
So other services. So the way we designed the plan at the Ministry of Health level, most departments, so most disease programs were involved in development of the plan. So immunization had to come up with a plan of how they will continue to vaccinate. So the malaria program was part of the team that developed the case management treatment guidelines. So ensuring that even though we are screening for COVID, is there a way we can also put malaria into that screening simply because of the presentation with fever. The other programs were also part of the planning. The thought would be that if you involve all these different levels in the planning process, then all the disease programs will be included. Having said that, at the operational level, what we try to do is designate treatment units. So we have 2 national referral treatment units and then another set aside just to receive suspect cases. So you try and decongest from the other health facilities so that you only have COVID in these, and then all the other cases can go to all the other health facilities. It seems to be working, but then that's at a first glance. Whether that is truly working, we will only know when we evaluate over a longer period of time.
Yes, so are you, because there's several questions on evidence, getting evidence, also having evidence for the contact tracing, for the testing strategies, and there's questions on how to coordinate all these, all the needs of all the questions which come, all the actions which have to be taken.
Okay. So the evidence for the contact tracing. So the strategy that was developed by the surveillance team looked at, in the beginning, if we can identify all the cases very, very fast and identify their contacts and test all of them to make sure that we don't have undocumented transmission, then we stand a chance to halt the transmission to the bigger population. We understand that once you hit maybe 100 cases, hundreds of cases, it's impossible to do contact tracing. It's impossible to link even to a single case. But with measures like you stop public transportation, you stop mass gatherings, you kind of simplify the contact tracing chain, so that it's not just random people that you're bumping into, but then it's more definitive people that you can identify. Then the evidence for the quarantine, the locking down, there are a few things. One, we looked at how China had implemented its lockdown, and it's reducing mobility and implementing travel restrictions, and had resulted in sort of like a lowering of their curve. The second bit of evidence is, if you look at the Public Health Act, which was enacted in 1935, a lot of the measures put in place in the Act depended on limiting movement. So based on all that, we put in place all these measures. You asked about coordination of all these sectors. The coordination is at different levels. There is the national coordination, which is headed by the president himself. Then below that is an interministerial committee, which is headed by the prime minister. Then for the technical implementation is the Ministry of Health incident management team, and then the pillars that fall under that. But then also under Ministry of Defense, there is a coordination arm that is monitoring the way all this works out, because it's all health security anyway. So there are several coordination bodies, but they all feed into the interministerial coordination body.
Okay, and it's working apparently. So
apparently it's working.
Yeah, there's some questions on treatments, like on chloroquine, on oxygen, on ventilators. Is there policies? Is there preparations?
So we are following the treatment guidance from WHO. So giving things like chloroquine and azithromycin as part of treatment protocols, as they've advised, not as definitive to everyone. Then for oxygen, that's why I mentioned the designated isolation facilities. We picked isolation facilities that had access to oxygen. And yes, and ventilators are also in specific places. So not everyone is being admitted in the National Referral Hospital. So that will be for cases that are at risk of becoming severe or would require ICU care.
Yeah. And convalescent plasma, are you considering that one?
I have not seen that one anywhere yet, but I would have to check, but I haven't seen it on any of the treatment protocols yet.
Okay. Let me see. There's a question about institutional quarantine compared to quarantine at home. Was that considered?
Yes, it was. We actually started with home quarantine. We had an assessment tool that we used to decide whether someone's home was adequate for quarantine. So do you have enough ventilation? Will the person be in the room by themselves? Is there a separate bathroom, a toilet? All these modalities were considered. And when you met the criteria, then you were allowed to have home quarantine. But then the numbers became big, and then we simply allowed people to have the home quarantine. But in some cases where the homes were applicable. But what we discovered with self-quarantine is that it depended a lot on self-discipline. So someone was put under self-quarantine in their home, and you check on them on day 3 and they've moved to a completely different part of the country. Or they report that they are not going to their workplace, but they are being seen at their workplace. At some point, I think we even had people advertising the fact that they had reported self-quarantining, but on social media showed that they were completely not adhering to it. And that's how the decision moved from applying self-quarantine to institutional quarantine.
Okay. A different question is about the management of dead bodies.
Yes. The management of dead bodies, we are currently following the WHO guidelines. So dead bodies have not been shown to be highly infectious, so managing them in the routine way. What we are limiting is the number of individuals that are allowed to manipulate the body, and limiting the number of individuals allowed to attend a funeral. So that's what we are limiting. So routinely at a Ugandan funeral, you'd find anywhere between 500 and 1,000 people coming to mourn. So that number has been shrunk down to about 10. In the president's words, I think it was 10 essential family members that needed to be there. But the management of the dead bodies themselves, we are simply following the WHO guidance.
Okay. And well, we 1 more minute. There's a question about traditional healers being involved.
So in the beginning of, right from the start, as part of preparedness, we engaged religious leaders, community leaders, and I think in some part traditional healers, just to make sure that they wouldn't advertise cures. But of course, engaging is one thing, and following through is quite another. We've been seeing quite a number of advertisements for treatments for COVID. We've been seeing people vaccinating individuals against COVID. We've been seeing quite a lot of this happening. But so what's happening is we are monitoring it very closely and intervening as it goes.
Because now the first patients will be discharged and will be returning to their communities. How will that go?
Yes. They will be taken back to the community with support from the psychosocial team and the risk communication team.
Okay.
Just to communicate the safety of the individual and to promote acceptability within that community.
Okay. There's still more questions, and questions pop up all the time. I think this is an epidemic which will continue to pose many questions to all of us, but I think we have to close, to let you go back to your work and us also to our things. I want to thank you. Okay. I also want to thank all the participants for asking very good questions. I tried to summarize them and pose as many as I could, but I see there's still many open questions. I hope we'll get to learn more of the experience of Uganda and of you in future seminars. And thank you very much.
Thank you too. Bye-bye.